move into the truly powerful and insightful part of our conference, our panel discussion. The theme of this session, panel discussion, not only ambitious but deeply essential. And today, we are incredibly fortunate to be joined by four global thought leaders for bringing a unique and the critical perspective to this conversation. And to moderate this insightful panel discussion, we have a very special person with us, Mrs. Sandrila Emmanuel Ma'am, Deputy Dean, College of Nursing at the Christian Medical College, Vellore. Ma'am, we welcome you on the stage.
Mrs. Chandrila Emmanuel Ma'am is an accomplished nursing professional with over 28 years of teaching experience at the College of Nursing, CMC Vellore. Ma'am holds a BSc and MSc Nursing in Community Health Nursing and is currently pursuing her PhD. Ma'am serves as Deputy Dean at CMC Vellore and Vice President of the Society of Community Health Nurses of India. Ma'am has contributed significantly through leadership roles, research projects, and curriculum development, and has published over 16 research papers. Ma'am has attended international training programs, delivered numerous national and international presentations, and remains an active member of leading nursing organizations like TNAI, CMAI, SOMI, SOCHNI, and NRSI. So, with great pleasure, I now hand over the proceedings to Mrs. Chandrila Emmanuel Ma'am to moderate this incredible panel discussion.
Everyone, and I thank you for that kind introduction. I thank the organizers for giving me this opportunity to moderate a very important panel discussion. As the theme of the conference goes, accelerating action for a sustainable future. Here we are to accelerate the action, and so we all are bound to get ready to know what are the actions that we are going to take. How many of you would like the future to be very nice and good and very pleasant for each of us? Can you put your hands up? Wow, that's nice. Most of us want the future to be very good for us, right? And with this adoption of Sustainable Development Goals way back in 2015 by the United Nations, some of it achieved, some of it yet to be achieved, some very doubtful whether it will be achieved. So many things are there, but we as community health nurses are the pillars. And there are pillars, 5 pillars to this Sustainable Development Goal, and we are one among them. The 5 pillars: people, planet, prosperity, peace, and partnerships. And we come as the first, the people. When we say people, it involves nurses. And when we say nurses, more so with community health nurses, because we are very close to the people and we really make a difference. This morning we are having very eminent panelists, some joining here in this room and some online. So we will be having a very interesting discussion on how we can accelerate the action, and we are having the first speaker, Dr. Esther Shirley Daniel. I would like Dr. Esther Daniel to please come to the stage, and Dr. Esther Daniel will be talking to us on achieving universal health coverage, which is very important as part of the Sustainable Development Goals, and what are the role of community health nurses. And Dr. Esther is currently the Vice President of SOCHNI as Overseas Vice President, and she is also a very dynamic leader. She is able to be very passionate. We can see the passion in her as to how the community health nurses has to function and how she will be able to progress in the future as we gather strength and unity in bringing people together to make this as a reality. In fact, it was she who had been very instrumental in coining this theme for this conference, and she has been able to bring this day to a reality. And she is currently the acting director at the University of the West Indies, Trinidad and Tobago. She is a very international speaker and she has a lot of experience in the field of public health nursing, and we are glad that you are here, ma'am, with us today, and thank you for accepting to talk to us on the universal health coverage, achieving the universal health coverage. We have two other speakers who are joining us online. I hope they are online. Dr. Jennifer Dawn, who will be talking to us on reducing maternal and child mortality, which is very, very important because it really requires strengthening community interventions so that we can be able to have mothers and child with good health, not losing them either in the pregnancy or childbirth. And again, children as they grow, we should be able to offer them the best so that the children will be having a good future. And we have another speaker, Dr. Suresh Sharma, who will be talking to us on the community-based approaches to combat infectious diseases and vaccination gaps. We all know few years back how the COVID hit us and how the infectious disease really put a halt on various spheres of life, and how the vaccination promotion was there and how we have overcome this infectious disease. And you know that in the future much more is awaited, that's what they say. So Dr. Suresh Sharma, who is the principal and professor at AIMS Jodhpur, is joining online as well and will be talking to us on community-based approaches. I request the audience to keenly take note of these presentations. We will be having a question answer session at the end of the discussion, and I wish that you would be able to throw questions to these panelists because they're all experts, and we will be having some idea as to what is this action that we are going to take in contributing to the achieving of sustainable development goals. So may I invite the first speaker to talk to us on how can we achieve the universal health coverage and what would be our role as community health nurses. Over to Dr. Esther Daniel.
Everyone, it's really a pleasure being here in this august auditorium, and I would like to thank Professor Siddharam Sarate for giving us this opportunity for SOCHNI to come to Gujarat and have our conference. I also bring greetings from SOCHNI to all of you, and also from the University of the West Indies where I work as the acting director of the School of Nursing. I bring greetings to you from that institution also. So today I have been given this beautiful topic of universal healthcare coverage. As the first speaker spoke to you about importance of food and other aspects pertaining to food, today we are going to discuss a little more about universal healthcare coverage. Now, my presentation will include all these topics, so please bear with me when I go into the details of universal healthcare. Some of it is not part of your curriculum, but since you are in the audience now, you will really appreciate that you will be updated with what is happening in the country and also what is expected of us as nurses to know about universal healthcare. Because today, after the epidemic of the pandemic, I should say, of COVID-19, people have realized the importance of community medicine, community nursing, and there is a whole lot of opportunities for you to have an independent practice in this beautiful field of community health nursing. So we are going to look at three dimensions of universal healthcare. What is Ayushman Bharat? The journey of universal healthcare, health and wellness centers, then Pradhan Mantri Jan Arogya Yojana, then you have reproductive, maternal, neonate, child, adolescent health and nutrition, Swachh Bharat Abhiyan, I'm sure all of you have heard about Swachh Bharat Abhiyan. Then universal healthcare, how to reduce disease burden. Then preventing, managing and controlling non-communicable diseases. How are we ensuring access to care? Expanding human resources, very important, because you cannot achieve any goal set by the Government of India if we don't have human resources. And leveraging digital technology, how are we going to incorporate digital technology into our services? And then the life cycle of multi-sectorial approach. You know, community health is not just a standalone profession. It has to take the multi-sectorial approach. Then how do we promote wellness through this multi-sectorial convergence? Challenges we have in India, and also as nurses, what are the challenges we are facing when it comes to universal health care, and how are we going to mitigate these challenges? And finally, the conclusion. So, as an introduction, universal healthcare is referred to in India as Ayushman Bharat. Now, Ayushman Bharat is a significant initiative and provides accessible, affordable healthcare to all citizens. These are the two words you have to keep in mind: accessible and affordable healthcare to all citizens in India. And people have full access range of quality health services. You know, most often people say the healthcare is not quality in government hospitals, whereas they go to the private players to get better healthcare. But Ayushman Bharat is telling, we are going to provide you with quality healthcare. And without any financial hardships. We all know if one person becomes sick in the house, the finances are drained out, isn't it? So here, the government is telling, through Ayushman Bharat, you will not have any financial hardship. And it's a continuum of essential health services, from promotion to prevention, treatment, and then rehabilitation, and please underline this, palliative care. Now we all know, according to Indian Nursing Council, there is a new module that has been introduced as a compulsory module under community health nursing for palliative care. So here we have added palliative care also to this Ayushman Bharat. And this started way back in 2018. Now the delivery of these services require a whole lot of healthcare workers with optimal skills, and we need a mix of these skills and health services who are equitably distributed, adequately supported with access to quality assured products and enjoy a decent work. So this is the introduction to Ayushman Bharat. Now the goal of universal health coverage is to ensure all people, when I say all people, the entire country receives the health services they need without any financial hardship. This is a very, very important point to keep in mind. Now the three dimensions of universal healthcare is: one, what is the population covered? Second, services covered. And third, the cost is covered. So it's all for all people in the country. Now, when you look at Ayushman Bharat that was launched in 2018, we have Ayushman Arogya Mandir and Pradhan Mantri Jan Arogya. Now these two programs were launched in 2018, but in 2025, the ones that are highlighted in blue color, Ayushman Bharat Health Infrastructure Mission and Ayushman Bharat Digital Mission was introduced. So we have two already programs under Ayushman Bharat. Now in 2025, these additional two programs were introduced. Now Ayushman Bharat Universal Healthcare coverage. Let's look at the journey. What is the aim of this Ayushman Bharat? Mainly to see the progressive integration of all subpopulations in the group, like adolescents, men and elderly. Usually these three categories of people do not have much access to healthcare. We do not have more services to these three categories of people. But now under this universal healthcare, we are covering these three categories of population. And also it ensures gradual inclusion of packages of high burden disease conditions. Now we all know that NCDs are really high burden, and these are included in the package. Now screening of 30 plus population for common non-communicable diseases. So all the people now, young people of 30 years above are started getting diabetes, hypertension, and they call it as work-related stress. So all of them are now being covered for non-communicable diseases. then significant gains achieved from a focus of reproductive, maternal, newborn and child health. So there is a lot of work being done in this area also. And the last one is strengthening quality and high coverage. They want to increase the quality of health coverage and strengthen it. So let us look at Health and Wellness Center. Now when you look at Health and Wellness Center, health is a state of complete physical. You all know the definition of health. So it's a complete state of physical, mental, social well-being, and not merely the absence of disease or infirmity. And wellness is, it's an active process of becoming aware of and making choices towards a healthy and fulfilling life. You have to be aware when you make a choice, whether the choice you're making is going to promote your health or it's going to promote disease. So you have a choice to do. It's more than being free from illness. It's a dynamic process and it's change for growth. Now the focus of universal health care and primary health care is global community. We are looking at a global community, and to achieve universal health care, primary health care is the foundation. So you all know about primary health care. That starts in the sub-centers, the first contact care or the basic health care we call it. So we need primary health care to start the universal health care. And then you have primary health care, which is at the full participation and at the cost that the community can afford. Now Astana conference in 2018 aims to commemorate the 1978 declaration to reaffirm the original principles and renew political commitments to placing primary health care at the heart of achieving universal health care coverage and the SDGs. This is according to Alma Ata Declaration in 1978. Now, as I mentioned, primary health care is very critical, and the important role is to prevent first and second degree diseases. Then it is also known as preventive, promotive, curative, rehabilitative and palliative aspects of care. And primary health care goes beyond the first contact care and is expected to mediate a two-way referral support. Now let's look at the health and wellness centers. You know, one side we have sub-center, other side we have a primary health center. Now sub-centers cover a population of 3,000 to 5,000, whereas a primary health center covers a population of 30,000, and in urban area it is 50,000. Now there are mid-level health providers, we call them as MLHP. They are either BSc or GNMs, that is BSc nurses or Gen nurse midwife, or Ayurveda practitioners trained in 6 months certificate program in community health, and you have community health officers now who are appointed at the centers. Now we have multipurpose workers, female, 2 per center, sub-center, and you have 1 multipurpose male who will provide this resources from the state. And you have 5 ASHA workers who do a lot of outreach in the sub-center. Now in primary health center manpower, how does the manpower look at a primary health center? You have an MBBS doctor, you have staff nurses who are 3 in number, you have a pharmacist, you have a lab technician, there's a health worker female, health worker male, accountant, and then you have a sanitary worker, you have ASHAs 4 to 5, and you have a multi-purpose worker female for every 10,000 population to cover the maternal and child services. Now we have, if you put the health and wellness centers, you must have an input, throughput and an output. So an input will be all your primary health care, the logistics, the infrastructure, digitalization, telemedicine, capacity building, health promotion and community mobilization. All this is your input. Your throughput is all your database, all the information that you collect, the community data. And then you have health cards and family health folders for every family. Then you have increased access to services. Now the outcome is, it's hoped that you have better population coverage, you reduce the out-of-pocket expenditures, because in our culture, we don't keep money aside for health expenditures. Do any of you keep money aside for health expenditures in case you become sick? I should keep some money. Do you do that? We don't do that because it's not in our thinking that we need to put some money aside. Of course, people do take health insurance. You know, you join a job, you will get health insurance coverage. That's different. But we don't keep money aside. But what the government is telling is, we will reduce the out-of-pocket expenditure. And also risk factor mitigation. We try to reduce the risk factor and decongestion of second degree and third degree level facility. You see, why we talk about this second degree and third degree, that is nothing but your district hospitals and tertiary hospitals. We don't want people to rush there, because that is a place where really patients who really very critically need the care. Now we have Pradhan Mantri Jan Arogya Yojana. Now Ayushman Bharat is a flagship scheme of Government of India that was launched and recommended by the National Health Policy to achieve the vision of universal health care. So it is definitely a government policy that is known as Pradhan Mantri Jan Arogya Yojana. Now this initiative has been designed to meet the SDGs, Sustainable Development Goals, and its underlying commitment, which is to leave no one behind. We don't want people to be left behind because they don't have money to access healthcare or they don't have means to access healthcare. So everybody is included in this. And this is a very, very popular scheme of the government. Now, what are the key features and benefits of Pradhan Mantri Jan Arogya? So, is the world's largest health assurance scheme. Is the world's largest, please mark my words, world's largest assurance fully financed by government. So nobody needs to pay any money towards this scheme. It provides a cover of 5 lakhs per family per year for secondary and tertiary healthcare hospitalizations. And it's across public and private impaneled hospitals in India. So there are a lot of hospitals that come under this scheme. And over 10.74 crore poor and vulnerable entitled families, approximately 50 crore beneficiaries are eligible for these benefits. It's amazing what the Government of India is doing. It is also providing cashless access to healthcare services for the beneficiary at the point of service. You don't have to have any cash. You just go. I'll tell you how you can be part of this later. It also envisions to help reduce destructive expenditure on medical treatment, which pushes nearly 6 crore Indians into poverty every year. You know, people, when somebody becomes sick and get hospitalized, and you don't have the means to pay the hospital bills, you borrow money and you are in debt. So it is a scheme to reduce this. It covers up to 3 days pre-hospitalization and 15 days post-hospitalization, such as diagnostics and medications. So you have pre and post period covered under this scheme. All pre-existing conditions are covered from day one. You know, there are insurance companies who will tell, if you have a pre-existing condition, you won't get the insurance coverage. Whereas this particular scheme by government covers everyone, whether you have pre-existing conditions or not. Now, services include approximately 1,393 procedures covering all costs related to treatment. There is no restriction on family size, age or gender. It's not that, you must have only 1 child or 2 child. Any number of people in the family are all covered. Benefits of the scheme are portable across the country. You may go for a visit to Kanyakumari, and if you become sick and you have the card, you can have the access there. It's not necessary you have to be in your own city to get the access. It covers more than 10 crore people and vulnerable families across the country, identified as deprived rural families and occupational categories of urban worker families. When we say occupational category, there are a lot of migrant people coming into the urban cities in search of jobs. Even they are covered. As per latest socio-economic caste census data, there is no capping on family size or age of members, which will ensure that all family members, specifically girl, child and senior citizens, will get coverage. Now, why is this mentioned? Because some of the insurance companies will not give you insurance if you are over the age of 80 years. So it's very unfortunate, when you become sick after 80 only. So if you're not getting your health insurance, then what's the point of taking insurance? So this scheme is available for everybody, irrespective of your age, irrespective of your family size and where you live, whether it's urban or rural. Now, what are the benefits under this scheme? Medical examination, treatment and consultation, pre-hospitalization, medicines and medical consumables, Then non-intensive and intensive care services, diagnostic and laboratory investigations, medical implantation services where necessary, you are having a cardiac problem, you may have a pacemaker or something like that. Then accommodation benefits, food services to the patient, complications arising during treatment, and post-hospitalization follow-up of 15 days. Now, what are the programs which work towards universal health care? Now, this is, I told you, maternal. Under maternal, you have maternal, neonatal, reproductive, child, adolescent, and nutrition. Under maternal, the delivery points, we have 23,240 delivery points established. Now, Prime Minister's Safe Motherhood campaign, which caters to 20 million antenatal care sessions undertaken since 2016. Then you have Lakshya, strengthens key quality processes in labor rooms. How many of you have conducted deliveries here? And those who are sitting in this auditorium? Definitely would have conducted deliveries. I don't see only one hand going up. All are not nurses? Are you all nursing? Then have you not conducted deliveries at all? They are saying no. Some, I'm not talking about the seniors. What about the people who are sitting at the back or in the middle? Have you all conducted deliveries? Not yet. Okay. Some of them nodding their head, some of them not nodding. So, the quality processes in the labor rooms and in the operation theatres, they are going to increase. And nurse practitioner midwifery cadre introduced. You all know that the Indian Nursing Council has introduced this nurse practitioner midwifery cadre to improve the coverage and quality of respectful maternity care. Anybody who wants to do their masters in community health or in OBG, you can go further and then do your nurse practitioner course. And it is very, very upcoming profession now, and you can have your own independent practice after that. Now, looking at newborn, state-of-the-art newborn care units is increased to more than 800 units established, catering to 1.1 million newborns annually. Home-based newborn care provided to over 12 million newborns visited every year. Active promotion of early initiation of breastfeeding. These are three important components of newborn care. Now, children, child. 33.9 million children and 8.8 million pregnant women reached through focused immunization drive. They call it Mission Indradhanush. You know what is Indradhanush, right? So it goes and hits the target. So this immunization is very important. You see, we talk a lot about immunization schedules. Sitting in urban cities, you see, oh, my population is immunized. You go 40 kilometers from any city and you will see that the immunization coverage is very poor. So we need more health workers to come forward to give the immunization for the rural community. Then intensified Mission Indradhanush, we need to reach the unreached, right? That is 18.5% in full immunization coverage. Unprecedented increase in the number of vaccines in National Immunization Program from 7 to 12. I am sure in year 2, you all study about immunization schedule. So you know that the Government of India has increased the number of vaccines from 7 to 12 now, which covers injectable polio, measles, rubella, tetanus, adult diphtheria, rotavirus and pneumococcal vaccine. Then 198 million children screened annually for the 4 diseases. What are the 4 Ds? Diseases, defects, deficiencies and developmental delays. All these are very important. These come under child schemes. Now coming to nutrition. We have nationwide Poshan Abhiyan. Have you heard about Poshan Abhiyan? I want you all to go back and read it up, right? This is nutritional campaign. This was launched as part of universal health care. We want to make anemia-free India. You know how India became free of polio, and some of you would have participated in pulse polio programs. So we want to make India free of anemia, which is a very preventable condition. So we have 3 production reduction per annum. That means in our statistics, we want to see that there's a 3% reduction in anemia cases every year. Annually, more than 70 million under 5 children are covered through intensified diarrhea, control initiative. So it's a huge number, we are talking about millions here. And more than 280 million dewormed annually under National Deworming Day. We all celebrate National Deworming Day. These are health days. So what do we do then? We go into the communities, we deworm the children in the slums or in the urban cities. That's an activity of NSS. So these are very important parameters under nutrition. Now adolescents. National Adolescent Health Program covers 253 million adolescents. 7 million adolescents
Sir, you
provided.
will have another 5 minutes.
Thank you.
Complete it.
7 million adolescents health services through 7,500 dedicated adolescent clinics. We in the primary health centers, there are adolescent clinics which the adolescents can always approach and take help. 40 million adolescents receive weekly iron, folic acid tablet and nutritional advice. Now family planning. Under family planning, 24 out of 36 states and union territories have attained replacement level fertility. You have Mission Parivar Vikas, where you are talking through communication to change the behavior. An intensified family planning campaign implemented to reduce unmet needs in 146 districts in India. Now 3 new contraceptives have been added to the basket of contraceptives. I am not going into the details now. Then we have Swachh Bharat Abhiyan. You all know about Clean India campaign that was launched in 2014 to achieve universal safe sanitation and improve the health and well-being of all Indians. We are hoping to eliminate tuberculosis in 2025. Definitely, a lot of work is being done to eliminate tuberculosis. There is an ongoing effort to combat tuberculosis through comprehensive treatment, partnership, community involvement and financial support. We also are hoping to reduce disease burden through viral hepatitis. World's largest viral hepatitis control program. We have it in India and we hope that 50 million people will be benefited. Free of charge diagnosis and treatment for hepatitis C and B. Treatment costs for hepatitis C reduced from 1,000 per day to less than 1 rupee per day. Then you have HIV and AIDS, over 80% decline in new infections, and from 1995 epidemic peak against a global average of 47%, 71% decline in AIDS related deaths since 2005 against a global average of 51%. Then preventing, managing and controlling non-communicable diseases, screening, capacity building, task shifting, expansion of primary care package and access to secondary care. In some of the places where we don't have access, this has been initiated. Then ensuring access to care is strengthening your public health infrastructure. You need to create a wide network of health facilities. Second is transport. Free ambulance services across India. Mobile medical units, you would have seen the medical colleges have mobile medical units. They call it as roam, right? So all these were to ensure access to healthcare. Now expanding human resources, that's where we are lacking. Undergraduate medical seats increased from 50,000 to 80,000 for the last 5 years. Postgraduate seats from 32,000 to 41,000. 1 million ASHAs and community health workers. The number of nurses, auxiliary nurses has doubled. Now you all know that colleges have been given directive from Indian Nursing Council that we can enhance the seats. And health force create jobs, especially in women. Then how do we leverage digital technology? Now the application to provide cashless and paperless treatment. You all know about GPay and Phone Pay. They can do their this thing. That is, we are not telling them to pay. We are telling them cashless. They don't have to pay a single rupee when they come into these schemes. Center for Electronic Health Records. We are trying to electronically do all the records. No more manual writing. Mother and child tracking system. We find out who is anemic, who is having a risk pregnancy. They track them. And My Health Record, mHealth. You can walk into any primary health center and apply for mHealth. You will get a card. Then you have integrated health information platform that is for monitoring 33 epidemic prone diseases on a real-time basis. Then you have NCD application, which is giving you continuous care and follow-up services. Then you have Nikshay, a web-based application for monitoring tuberculosis patients. Now, tuberculosis patients, they have a multi-drug resistance. They stop their treatment. They don't continue. So that is one thing that they are trying to overcome. Then drug and vaccine distribution management system. This is another. They have even an SOCHNI software for that. Then you have E-Rakshak, a centralized blood bank management system. Mera Aspatal, that is an application for real-time patient feedback for health services. And you have WHC portal, a health worker portal for monitoring various components of health work. Now we have this Amrit. It is affordable medicine, reliable implants for treatment. You heard about pharmacies run by Government of India? Jana Pharmacy, have you heard? You get very, very cheap the medicines. Even glucometer, which is costing about thousands, you can buy one glucometer for 500 rupees in this Jana Pharmacy. Then Prime Minister Bharatiya Janaushadhi Prayojana, that is a place where you can afford to buy all these medicines which are very good. Now I am skipping all this. You have to promote universal healthcare through multi-sectorial approach. You need to bring in behavioral change in communication, yoga sessions, Fit India movement, make people to eat right. You can't just have a one type of lifestyle. You need to change your lifestyle. Then you need Ayushman Bharat health and wellness ambassadors to promote wellness and regular physical activities. Then you need funding and financial sustainability. Insufficient healthcare facilities in rural areas. There's no proper infrastructure and medical professionals are not available. That's why the Government of India is telling now all medical students should do compulsory 2 years of community primary health center services. Now that may come to nursing very shortly, we do not know. So availability and affordability of essentials, medicines and medical technology. Now what are the challenges of implementing healthcare in India? First of all, we don't have integrating health records. That is something that's coming up in a big way now. And coordination across different sectors, private, public, governmental, non-governmental. Lack of awareness. Many people are not aware what is this scheme about. So that and how they can access the scheme. Now we have workforce challenge, inequitable distribution, low wages and job insecurity, limited scope of practice. So we need to put in place, especially for nurses, insufficient people to deliver the universal health care. We have urban-rural disparity. There's a high turnover and migration. I'm sure all of you know the minute they finish BSc nursing or general nursing, they're 1 foot already in a foreign country. They want to migrate. So that is affecting the delivery of healthcare services in the community. And then underutilization of skills. Nurses are not being utilized what they are trained for. Lack of professional development. People feel they're stagnated, there's no personal growth. Poor nurse to patient ratio has compromised patient outcomes. When you have very few nurses to take care of large number of patients, you're compromising the care that is given. Then limited career growth. There's low motivation and there's brain drain. Occupational stress and burnout is a challenge. So reduced efficiency and mental health concerns are raised. Weak policy representation. Nursing perspective underrepresented. Because in most of the big discussions, policy changes or advocacy, nurses are not on those panels. Because nurses are not strong enough to be represented, and the government always does not value the voice of the nurses. So we need to raise up and then make sure that we are all part of all this planning and advocacy. So how do we strengthen nursing at universal healthcare in India? You need to expand your nursing education and training capacity nationwide. We need to increase the number of seats in the nursing schools and colleges. We need to offer scholarships and incentives to attract candidates to nursing. Nursing should never be a last choice. People should not come into nursing because they didn't get anywhere, they came into nursing. We should invite people who really want to do nursing. Then ensure equitable deployment of nurses with rural service incentives. You want to work in the rural. Many of the students, when they finish their community posting, they are very motivated, they want to work in the rural. But there's no incentive, there's no motivation for them. So we need to create that. Improve healthcare facility infrastructure and working conditions. give them proper housing, give them proper salary, give them resources to work in the community. Standardize salaries and ensure job security for all nursing cadres. Empower nurses through expanded scope of practice and legal recognition. Then you promote and fund continuing nursing education, digital learning platforms, ensure recommended nurse-patient ratio across the healthcare setting. We talk a lot about healthcare and nursing, nurse-patient ratio, but it has to become a reality. Then provide mental health support and promote work-life balance initiative. Strengthen the role of nursing councils and include nurses in health policy decisions. So to conclude, achieving healthcare coverage in India is a necessity for equitable access to quality healthcare. Significant progress has been made through Ayushman Bharat. Now remember, whenever people talk about universal healthcare, the next thought should be Ayushman Bharat. That is the healthcare, universal healthcare in India. Then persistent challenges include inadequate infrastructure, workforce shortages, financial barriers. All these have to be dealt with. Then addressing this issue requires increased investment in health system. You need robust policy frameworks, enhanced community engagement. Prioritizing these efforts will help India develop a health system that provides comprehensive, accessible and affordable care to everyone. This will ultimately lead to universal health coverage for all. Thank you so much for your patient listening.
Thank you, Dr. Esther Daniel. I'm sure this was informative to the audience. Audience, do you have any questions? If you are not asking, I'm going to ask you. Okay, so keep thinking and you can ask your questions at the end. Thank you very much once again, Dr. Esther. And audience, do you know how many mothers would have been lost by the time this presentation was over? Any guess? The statistics say that at least about 20 mothers would have died due to maternal causes. Every minute there are 2 mothers dying. So we have the next speaker, Dr. Jennifer, who will be talking to us on reducing maternal and child mortality. How can we reduce this? By strengthening community health nursing interventions. So Dr. Jennifer from Columbia University, USA, I'm thankful to her to sparing her time in spite of the difference in the time zone. So over to Dr. Jennifer.
Thank you. Can you hear me?
Yes, very well.
Good. If you could pull up my presentation, Suresh. While he does that, I just wanted to say that I'm really very honored to be here, even though I'm far away in New York, just after midnight. But it's very exciting, and I'm really grateful for the work of the Society of Community Health Nurses of India and their wonderful international conference 2025. I feel like the previous speakers have already touched upon so many issues that are critical to me. And I hope that this is a rigorous learning and exchange session for everyone that's involved. And many thanks to Dean Sarate of CVM for organizing this, and of course with Dr. Esther Daniel, my colleague and friend, University of West Indies, Trinidad and Tobago. Thank you so much for inviting me. So maybe who can pull up the presentation? I don't know that I can pull it up from my end. you, and I'll just tell you when to go forward. So I'm speaking today on reducing maternal and child mortality, strengthening community nursing interventions. I've been a midwife and women's health nurse practitioner all of my clinical years, something that's very, very important to me, and to share my ideas with you. Next. Suresh, can you just forward it, please? I always start by something that many of you probably know, but by saying or reading a poem to bring us together. So this is an African proverb. If you want to go fast, go alone. If you want to go far, go together. And as nurses, I say we do the latter, right? We go together and we therefore make progress. We are the largest cadre of the health workforce. So nurses are in a really great position to make fundamental changes if we go together. Next. I always start by saying that we should take a moment of silence to really honor all of the nurses around the world serving in the battle against pandemics, against spread of war, migration, climate change, non-communicable diseases, communicable diseases, that we really have an amazing community globally that moves together. And here on the left, upper left, is a picture of nurses in Eastern Cape, South Africa during the HIV pandemic. Here are nurses who were part of the Regulatory Council in Liberia. This is pictures of people who lost their lives on the front line of Ebola. These are nurses in Wuhan, China, during the first days of the COVID-19 pandemic, ready to go to work. And here are nurses in New York in April of 2020. And I know all of you can think of nurses that you've worked with, that you honor, whose shoulders we stand on. Next, please. So maternal health is a human right. That's where I start all of my talks. So this was a question just asked a few minutes ago, but around the world in 2020, almost 800 women died each day due to complications of pregnancy and childbirth. And the important thing is an unacceptable figure because they are preventable. The great majority are preventable. The risk of a woman in a global south country dying from maternal-related cause during her lifetime is about 130 times higher to a woman living in a global north country. Unjust, right? Women are not dying of diseases we can't treat. They are dying because societies have yet to make the decision that their lives are worth saving. And that was by a past president of the International Federation of Obstetricians and Gynecologists. And so, you see, women are dying from things that are preventable, and because societies haven't decided that our lives and the lives of pregnant women should be primary in given care. In June 2010, the United Nations Health Rights Council passed a resolution recognizing maternal mortality as a human rights concern. An important statement, but this comes almost 60 years after the founding of the United Nations. So I mean, why it takes so long for them to say that this is a human rights concern? Next, please. So when we have a framework for this conference of the United Nations Sustainable Development Goals, the SDG vision is to reduce maternal deaths to less than 70 per 100,000 live births. So that's the goal, right? And we want a lot lower than that. But if we look, next please, if we look at the map of the world, we will see that many, many, many countries are way exceeding that, particularly the countries in darker orange, countries in red, most of sub-Saharan Africa. You can see the differences, and if you draw a line, you can see that you prefer to give birth to this, looking at this map, in a country like Canada or Australia, or European Union countries that have very, very low rates, but it's not equal across the world. And since we are a global profession, We have to look at our responsibility regionally, in country, and globally. Next, please. So, the high number of maternal deaths in some areas of the world reflects inequities in access to quality health services with skilled health professionals, including nurses, midwives, and resources. So maternal mortality rates, MMR, in global south countries in 2020 was 430 per 100,000, much too high. Remember that we have the goal of the Sustainable Development Goals of 70 or less. In global north countries, it was 13 per 100,000. Now look at this figure I came up with for India. MMR has declined from 384 in 2000 to 103 in 2020. So in 2 decades, we cut maternal mortality rates by 2/3. That's very, very good. That's very, very impressive, right? That you could bring it down. And if we look at the goal of 70 for the Sustainable Development Goals, there's still much work to be done. Next, please. The Lancet issued a call to ensure where a woman lives is not determined if she lives, right? This should happen locally, nationally, and globally. That every woman, every newborn has the right to good quality care. Quality, equity, good health systems, good financing, and better evidence. Next, please. So why are women dying? What are the interventions that can be done? And if we look for 1 second at this map, we'll see some of the greatest reasons women are dying are hemorrhage, right? We know how to manage, we know how to participate in most cases and manage. They're dying from other maternal diseases, and they're dying from sometimes as results of unsafe abortions or miscarriages. That's the goal, which are things that we could easily deal with. Next, please. So I propose that we consider 5 basic elements for interventions in this discussion. What we can do. We need nurses and midwives who are competent to prevent, diagnose, treat, and refer. Right? So we need skilled professionals of nurses. We need timely referrals to proper facilities. That means the ability to get from the lower level, community-based service, to a tertiary hospital. Has to be referred timely, and there has to be a means to get there. Regular antenatal care. As nurses, we all know, one of the best ways to prevent maternal morbidity and mortality is for women to come and get screened regularly, because we can identify most problems that occur labor as part of if we are involved with the women and the family during the antenatal. And we need adequately supplied care centers at community levels. It has to start in the community with nurses in the community. We are the central link to the community. Early enrollment in antenatal care, we can go out and get women who are pregnant, speak to groups, encourage women to come in early. Education, sharing our knowledge of how women can improve their health and maintain good health during their pregnancy, and how they can recognize and identify and come to us when it does not seem okay. Cultural respect. The community and the cultures that we live in are very important to maintain a healthy pregnancy. And who can better do that than you, nurses at the community level? You hold the key to this. Connection to higher levels of care. So we have to have the ability to identify problems and to move them to higher levels of care. All this can be done by nurses if we're well-staffed and trained, educated, within to serve in their communities. This is where it has to start. This is why your society is so very important in looking at what we can do next. Go on. So, nursing and midwifery, with lots of evidence that we can be the central solution. It's essential for a robust maternal health system. And I use the word nurse and midwife. I know many countries have different systems, but a nurse who is specialty in midwifery and perinatal care was the term I'm referring to. United Nations Population Fund, International Confederation of Midwives, and WHO said nurses and midwives can meet about 90% of the need for essential sexual, reproductive, maternal, newborn, and adolescent health interventions. We're a vital solution, and we need to be at the policy level to really influence the district's implement. If you have the ability to provide the care, you can. Next, please. So I want to just look at a couple of case studies as examples of community health nursing that improve maternal infant care. The first example I'm showing is at the clinical level in South Africa, where I had the ability to work for many years, especially during the HIV pandemic that started there. And what happened was women, especially in rural areas, who were pregnant, faced stigma, faced isolation. They thought that they would die, their babies would die. So men were reluctant to come forward for antenatal care. And it was the nurses. I have a picture here on the left of Sister Primrose Latsina, who was a charge midwife and nurse in the ZZ Clinic in the Eastern Cape province. She went door to door to her community. This is the value of your work, of being based in the community, and encouraged women to come forward and said, need to enroll in prenatal care. We need to be able to test for HIV. We need to be able to get the medications to prevent transmission to your baby, but you need to come into care. And here was her persistence, going into the community and having all of the nurses that she was in charge of go to the community that made fundamental changes. So you have this picture in 2006, and 4 years later, you have nurse-initiated and managed ART, antiretroviral treatment in South Africa. What a major victory that was, right? That nurses at the primary care level, at the community, would have the skills and training to initiate and manage women who are HIV positive safely, and this greatly reduced the infections transmission to babies. Major, major victory for all of nursing. Next slide, please. Another example is what happened in Ghana. And I find this very impressive, and that link will show you a video. It's called No Woman Should Die Giving Birth. In Ghana, midwives deliver. So the government Ministry of Health identified the problem, that their maternal mortality is way too high, and that they needed massive intervention. So you have political will, right, behind identification of a problem, that have too high levels of maternal mortality. Strong partnerships with government partners with the International Independent United Nations. And they looked at midwifery, we say nursing-based solutions, which is to educate more nurses to prepare antenatal care, perinatal care, and a commitment to rural areas. There were problems like they made free maternity services. This is universal health care. Dr. Daniel just spoke about the importance of having this, and staff facilities. So we have to have facilities in the community, right? We have to have free maternity services. We have to have educated nurses who are committed to working in rural areas, and a political will to make this happen. And what the nurses did, who worked into the community, was they engaged the community. They assessed issues and addressed them. They went to the elders in the community and talked to them about why a woman should come and work in a facility that had equipment and that had trained staff. They involved with opinion leaders and women. This has to happen. We can't just say we're here and expect the community to come running. We have to ask them, we have to empower them that this is important. And if people understand that it's going to improve women's lives, babies' lives, people want to be part of this, but they have to be brought in. And nurses need to do this. This is what we do. Next picture. And I want to give an example of what I did in the South Bronx, New York, which was a community that had terrible mortality statistics. This is the childbirth center in Morris Heights when we first opened. Next slide. So the United States, we're the only highly resourced country with a rising maternal mortality rate. So yes, it is lower than the SDG vision, but it's rising. And why is that happening? It went from 1987, 6.6 deaths per 100,000, in 2018, 2.8 deaths per 100,000, in 2022, 2.3 deaths. Why is it going up? And especially amongst women of color in the United States, African American women, who are twice more likely to die in the perinatal period than men. So midwifery models of care that encourage women's participation can offer a way towards safe motherhood. I want to show you a bit of what we did. We go next. So here's just a slide to give you a comparison. So of all these countries, starting with Norway, Switzerland, Sweden, you see where the United States stands in terms of high-income countries, way down the list. And if you're the black woman in the United States, look at this figure, more than 2.5 times. So that's an issue of racism within the healthcare system in my country. And it's up to each country to determine who's included and who's excluded. But this is historically true for the United States. And I'm showing you because this birthing center that I led was built in the community primarily of black and Latino. Next slide. And out of this piece of work, I published a book a year ago, Mothers, Midwives, and Reimagining Birthing in the South Bronx. Breathe, not push. I think that's the slogan of many of us that work in birthing, right? We get organized, we take a breath, and then we can push the ball forward. Next slide. So from 1988 to 2012, thousands of pregnant women received their care at the childbearing centers in Morris Heights. In a community with high rates of maternal infant growth, mortality, and morbidity, it became a thriving hub for women to learn and helps to direct their care. It was the community that was engaged and that was empowered. And what we learned here, what we had during those 24 years, no maternal or infant deaths. The cesarean section rate of those who were transferred to the hospital was under 10%. And in the United States, the cesarean section rate in the general population was 34%. So the cases that needed more intervention still were able, with timely intervention, to deliver vaginally. And women started care earlier. So this was very important because before antenatal care is critical for maternal mortality. So next, show a couple of slides. And what came out of, I did interviews with women, I did oral histories and then analyzed them to see what they could tell us, women who had birthed there, what they could tell us. And they really pulled out 5 themes. They pointed out to the racialization of the U.S. healthcare system, and we needed a different approach to living healthcare that's inclusive, that midwifery care or skilled nursing care is central to safe maternity care, that generational trauma, women's mothers have died in childhood, for example, could be transformed and healed through pregnancy and birth experience. Birth experiences can be a time of empowerment at family and leadership levels, and the centrality of community health and nursing interventions early. And there were many of them that we did. Next slide. So examples, antenatal care began in the community. There was a leaflet that I made when we were opening this center, and I took it everywhere. I took it to teachers' meetings, parent meetings. I took it to churches and temples and mosques, right, to talk about the childbearing center. Everywhere I could go to invite people to come and talk. I engaged the elders, especially elder women. Come into the center and let's look at what we're doing. Most had a tradition of midwifery care, and they wanted to know what kind of midwifery care we were offering. We really respected cultural practices with the birth experience, and we really invited women and their families to be involved in care. It's very important that a family can feel empowered that man can feel part of the birth experience, the woman can feel that she is respected and can have birth with dignity. And we had connections to higher levels of care, obstetricians and tertiary. Next. So I just want to conclude by saying, this is a conclusion I made in my book, Breathe Now Push. A close listen to the voices of these women provides repeated affirmation of what is needed to move from the current time when maternal health is not a basic human right for all women to a new era of safe motherhood that is inclusive and equitable. What matters is loud and clear. In terms of the United States, it's constructing racialization, inequity, caste, right? Maternity care matters, environment matters, being in the community is central. Having a place that people can come to easily and their families can be involved. Culture matters. Very important to respect and keep the culture that people bring because there are great rituals that should be honored in birth. The voice in care and policy matters. We need to ask women and families what's working for you, what's not, and change it. And nurses can do this. We are the connection to the community. And growth and self-empowerment of women matters. I think that this is a birthing experience should be a healthy, a safe one, and it should give a sense of empowerment to women and their families. And I think that we can push this agenda forward. I'm very, very honored to be speaking with you and have a look at how you as a society of community-based nurses look at moving forward on the critical issue of maternal and infant well-being. Next. There's one more picture that I didn't share. So this is a mural that was painted during the COVID pandemic when 900 people in New York State were dying each day in the early days. 900 people each day. And someone put up this painting, and I loved it because it was a thank you to all the nurses working in the community and in the hospitals in New York City. So I say thank you to you, and together we will go forward. Thank you.
Thank you, Dr. Jennifer, for a very informative session, and we really appreciate your willingness and sharing your rich expertise with us. Thank you also for advocating on the key changes that are required in bringing down further the maternal mortality in our country. Once again, a big thank you from the audience and from the organizers. We'll have the inauguration, and followed by that we will have the last panelist to speak to us. Thank you.